Good morning. I'm presenting topic for today, and the topic for today is role of dental calculus in periodontal disease. This is a very important chapter. All of you know that plaque is a etiological factor for development of initiation and development of periodontal disease, but calculus serves as a reservoir. Means calculus is not a etiological factor, but this is a contributing factor in the development of periodontal disease. Now come to the first slide. Calculus is a hard deposit that is formed by mineralization of dental plaque on the surface of natural teeth and dental prostheses, generally covered by unmineralized plaque. Means calculus is always covered by a layer of plaque. Classification. Basically, this calculus is of two types. First is supragingival calculus, another is subgingival calculus. Now come to the supragingival calculus. Supragingival calculus is tightly adherent calcified deposit that forms on the clinical crown of the teeth above the pregingival margin. Means supragingival portion means above the gingival margin. It is clinically visible. It is also called as salivary calculus because it forms from saliva. Means the components of this calculus is derived from saliva. That's why this is called as salivary calculus. This is a picture shows supragingival calculus in the lingual aspect of the lower anteriors. You see the calculus amount of calculus deposited on the lingual surface. Now come to the second type of calculus according to location. Second part is called as subgingival calculus, and this is calcified deposit that formed on the root surface below the pregingival margin, means below gingiva. It is believed to be formed from the gingival exudate and hence called as ceremal calculus. Means the components of this part of the calculus, subgingival calculus, is derived from, constituents are derived from serum, means the gingival clavicular fluid components. This picture shows subgingival calculus in the gingival margins. Below gingival margins, you see hue of the calculus from upper and lower arches. Structure. Supragingival calculus are usually whitish yellow in color and can be stained by tobacco or food pigments. Its consistency is hard and clay-like. Basically, this is hard. They derive from mineral salts from the salivary secretions. Hence, these are more abundant on lingual surface of the lower anterior teeth, opposite to Watson ducts and Bartholin ducts and the buccal of the maxillary molars, and opposite to the Stisson's duct. Means this calculus is more frequently found where the opening of major salivary glands occur. Means जैसे सबलिंगुअल एरिया के आसपास ही जो है वो लोअर आर्च में, लोअर जॉ में opening of salivary ducts, salivary glands like submandibular and sublingual ducts open होती हैं, and buccal aspect of the maxillary second molar के आसपास जो है वो parotid की opening होती है. So the chances are more deposition of calculus is more in the buccal aspects of the maxillary molars and lingual aspect of the lower anteriors. See amount of calculus which is deposited in the lower anterior lingual aspect. Subgingival calculus is a brown or greenish black in color and deposits are firmly attached to the tooth surface. This is more adherent to as compared with supragingival calculus. These are firm and hard and cannot be removed easily. These are found on any root surface with periodontal pocket. Are you getting my point? Okay. They are commonly ring-like or ledge-like formation, crusty, spiny, or nodular deposits because of the circumferential excretion of gingival clavicular fluid. The components of these subgingival calculus are derived from the serum. So this is also called as serumal calculus. Less commonly seen as finger-like or fern-like formations. These are the pictures. These are the pictures of these are photographs of subgingival calculus showing subgingival deposition of greenish calculus over the two pictures. Now composition. It has two components, organic and inorganic part. Inorganic part in percent wise, basically it has a 70 to 90% inorganic content. In this inorganic content, the principal ingredients are components are calcium 27 to 29%, phosphorus 16 to 18%, sodium 1.5 to 2.5%, magnesium 0.6 to 0.8%, fluoride 0.003 to 0.04%, and crystal forms of hydroxyapatite 58%, magnesium white 21%, octacalcium phosphate 12%, and brucite 9%. Among organic components, the constituents are mixture of protein polysaccharide complexes, discomet epithelial cells, leukocytes, and microorganisms are 1.9 to 9.1%, proteins 5.9 to 8%, 8.2%, and lipids 0.2%. So this is a picture of organic components of calculus. Now how it forms. Calculus is formed by precipitation of mineral salts between 1st and 14 days of plaque formation. 1 से 14 दिन लगते हैं calculus बनने में. In 2 days, plaque can be 50% mineralized. 2 दिन के अंदर plaque 50% mineralized हो जाता है, and the 60 to 90% gets mineralized in 12 days. Now calcification. Calcification starts in a separate foci on the inner surface of the plaque, and these foci of mineralization gradually increases in size and collapse to form solid mass of calculus. Now calculus formation. Calculus formation continues until it reaches maximum levels in about 10 weeks and 6 months, after which there is decline in its formation due to mechanical wear from food and from lips, cheek and tongue. ये लगातार कंटिन्यूएशन मोड पे बनता रहता है, बट ये होता है कई बार फ्रिक्शनल फोर्सेस जो आपके फूड से, चाहे आप लिप्स या चीक्स या टंग से होते हैं, धीरे धीरे ऊपर की लेयर इरोड होती रहती है. दैट्स वाई एक लेवल पे आने के बाद इसकी थिकनेस बहुत कम बढ़ती है, क्योंकि आप ब्रशिंग भी करते हो, आप खाना भी खाते हो, वेयर एंड टियर फ्रॉम लिप्स भी इस पे रगड़ते हैं, चीक्स भी रगड़ते हैं, टंग रगड़ती है. तो एक लेवल पे आने के बाद धीरे धीरे इसका जो डिपोजिशन रेट है वो घटने लगता है. लेवल तो सेम रहता है, बट वेयर एंड टियर के कारण वो लगभग एक कांस्टेंट मोड में आ जाता है. This decline is referred as reversal phenomena. Now, कैसे ये डिपॉजिट होता है? There are various theories given by various scientists, but the most acceptable theories are 3: booster mechanism theory, epitactic concept, and inhibition theory. These are the 3 most acceptable theories of calculus formation. In booster mechanism, according to this theory, precipitation of calcium and phosphate salts results in local rise in pH of saliva. Factors such as loss of carbon dioxide and ammonia could lead to rise in pH. The other ways by which precipitation of calcium phosphate salts can occur are: the first is colloidal protein in the saliva bind to calcium and phosphate ions, thus producing a supersaturated solution. When saliva stagnates in the oral cavity during night especially, colloids settle and result in the precipitation of calcium and phosphate salts. रात में सोते हैं हम, salivation decrease कर जाता है, stagnancy आ जाती है. इसकी वजह से जो सुपर सैचुरेशन प्रोसेस होता है, सुपर सैचुरेटेड सोल्यूशन बनता है, उसके कैल्शियम एंड फॉस्फेट साल्ट्स प्रेसिपिटेट करते हैं टू सरफेस के ऊपर. especially openings of glands के आसपास के area. Now, if phosphatase liberated from the dental plaque, desquamated epithelial cells or bacteria precipitated calcium phosphate by hydrolyzing organic phosphates in saliva, thus increasing the concentration of free phosphate ion. Basically, when the concentration of free phosphate ion increases, the deposition rate will also increased. Now, second concept is epitactic concept. According to this concept, seeding agents induced a small foci of calcification. Thus, foci and large and collapsed form calculus. मतलब छोटे छोटे जो है वो बीज रूपी जो है वो कैल्सिफिकेशन एरियाज डेवलप होते हैं और आपस में जुड़ के एक बड़ा कैलकुलस का पार्ट बना देते हैं. एंड these seeding agents in calculus are not clearly known. ये seeding agents क्या होते हैं, कौन से फैक्टर्स होते हैं जो seeding agents को precipitate करा के इनको आपस में जोड़ते हैं. But suspected agents should be intercellular matrix of plaque, carbohydrate protein complex, and plaque bacteria. Now, third theory of calculus formation is inhibition theory. This theory considered the possibility of calcification occurring only at special sites because they exist in inhibiting mechanism at non-calcifying sites. Wherever calcification occur, the inhibitor is earlier altered or removed. One such inhibiting agent could be polysulfate, which prevents the initial nucleus from growing, the possibility of poisoning the growth of center of crystal. This is a very complex theory, but in short, you can say that जिस जगह पे इनहिबिशन होता है, ठीक है, उस जगह पे जो है वो हट जाता है, अपने आप डिपोजिशन होने लगता है. पूरे ओरल कैविटी में हर जगह जो है वो कैलकुलस डिपॉजिट नहीं होता. देयर आर इनहिबिटिंग फैक्टर्स, जहाँ पे इनहिबिटरी फैक्टर प्रीडोमिनेट करते हैं वहाँ पर डिपोजिशन नहीं होगा. जहाँ पे इनहिबिटरी फैक्टर्स डिमिनिश हो जाएंगे या अल्टर्ड हो जाएंगे या रिमूव हो जाएंगे, वहाँ पे कैल्सिफिकेशन होगा. तो दिस इज ऑल अबाउट कैलकुलस. एंड अब इसको कैसे हम प्रिवेंट कर सकते हैं? देयर आर सर्टेन एजेंट्स, सर्टेन मैकेनिज्म बाय व्हिच यू कैन प्रिवेंट कैलकुलस फॉर्मेशन, and these agents are anti-calculus agents. In this, we will talk about according to generations. The first generation agents are disclosing agent. First generation agents are dissolution agent, जो calculus को गला देते हैं. In this, the agents are acids, spring salts, sodium rinosolate, and resinolate, and plaque attachment inhibitors are silicons and ion exchange resins. Plaque inhibition agents are antibiotics, especially neomycin, and antiseptics like chloramine T. Matrix disruption agents are enzymes like mucinase, ascorbic acid, sodium percarbonate, copper sulfate, and sulfite, and 30% urea. These are the plaque dissolution agents or calculus dissolution agents. Now, second generation are basically they prevent crystal growth. In this, vitamin C, pyrophosphates, diphosphonates, zinc salts, calcium lactate, sodium fluoride, copolymer, citroxin, and sodium citrates are the available agents. Now, commercially, one anti-calculus product which is used as a antiseptic mouthwash is it has an additional benefit that it is recommended by World Health Organization. It is a cationic bisbiguanide, and it inhibits anti-plaque and it has anti-plaque and antibacterial property. It has also anti-calculus activity, and this is effective against gram-positive and gram-negative organisms. And the concentration is 0.2% chlorhexidine, 10 ml for 2 minutes twice a day for not more than 14 days. So this is all about your calculus as a predisposing factor for in periodontal disease. I hope that you will learn from this chapter, and frequently ask short notes. If you go through last 10-year papers or any MCQ pattern questions, you'll find that in every question paper or every MCQ questions, this the questions from this calculus chapter will come. Okay, thank you.